but the key knowledge is what structures can you damage. So someone who doesn't release the ulnar nerve, doesn't look for the ulnar nerve, or damages it, is an unsafe surgeon. So one of the key factors with the posterior approach is, once you've gone through the skin, fat, fascia, you've identified the triceps, is to identify the ulnar nerve, to release the ulnar nerve and make sure at all times you know where it is and that you're protecting it. And that can lead to a series of questions about the ulnar nerve, nerve roots, courses within the body, which you also need to know as well. Because if you're going to ask anything about the posterior approach, usually it's about the ulnar nerve, because it's one of the main ones that you're at risk of damaging during your approach. Deep dissection with this case has already been reflected off with relation to the olecranon fracture. However, you can do a trans-triceps approach. You can do an olecranon osteotomy. Personally, we don't like to violate the ulnar if it's not broken, but it's obviously an option. And if that's what you've been trained up to do and you can do, then that is something that you can discuss during the examination. But obviously has a risk of non-union and removal of metalwork if you were to tension band wire it. So carrying on through our approaches, we then go on to our structures at risk, so the ulnar nerve. So if I was an examiner, I would then probe your knowledge of the ulnar nerve, the nerve roots, the courses, and you can see how these series of asking you your approach, the posterior, then they have leading questions from it, deliberately to test your anatomy and that you're a safe surgeon. So they could ask any of the nerves around the elbow, because you could potentially damage all of them during your surgery, and vascular structures as well, and the ligament complexes. The ligament complexes are particularly one to do, asking candidates to draw, and during the examination you can be asked to draw. And the whole point of all of these is testing your anatomy knowledge, testing your methodical approach to answering the question, and that you're a safe consultant as well. They may show you horrendous fractures like this, which I'm sure Andy will go through later about classifications from it, from a top unit in the UK, and then we can talk about your approaches. So with this, we've already highlighted the Cocker, modified Cocker approach can approach the lateral portion. So I would do a combined approach with a modified Cocker, posterolateral approach, and a medial approach. Now, there are a large number of medial approaches described in the literature. Personally, I use a Hotchkiss approach, particularly to allow you to get plating or fixation of the coronoid in unstable elbow fractures, which Andy will go through later. The approach itself, superficially, you can use to gain access to the ulnar nerve, gain access to the coronoid for fixation. So personally, I do this in appropriately consented, optimized position patients, supine board with or without tourniquet, tranexamic acid, prepped and draped. That's your blurb you say, and then you progress onto your incision and landmarks. So you mark up the medial portion with a curving incision over the medial portion, and you come to your internervous planes. So you highlight the two tendons that you're going in between, and you're highlighting the nerve and the understanding that PL isn't present in everyone. And so as you're talking through your approach, you're going, I do the skin, fat, fascia, you then put a self-retainer in, reflecting back the tissues and identifying the two tendons that you're looking for. And if you haven't mentioned internervous plane, they will probably ask you the nervous innervation of them. And now a nice tip or statement you say is about identifying vessels that perforate through the fascia. So these little statements tend to give the impression that you know what you're talking about, that you've done it before, and that you have an understanding of anatomy. And then progressing on, you come down to the deep dissection. You go on about peeling off brachialis, staying onto bone to try and protect those anterior structures, and you develop it down to the coronoid and to the capsule itself as well, giving yourself a great exposure to the elbow, particularly allowing you in your elbow dislocations to get a good approach to the coronoid in particular. Now, this is an approach everyone does. So the medial approach is something you need to know. You definitely don't need to know all of them, but it's important you have one of them. This one actually has minimal structures that you need to memorize. It's quite a quick approach into the elbow, but it also can lead on to the discussion of what's at risk during it. It's the medial ligaments of the elbow, the median nerve, ulnar nerve. So they could easily ask you about any of those and progress down a question pathway, which then goes down asking you on your anatomy knowledge of it. So when they come to approaches, they're testing your knowledge, they're testing a methodical approach to answering the question that will demonstrate that you're a safe consultant. So you know what structures are at risk, you know what you do to try and avoid them, and therefore demonstrating to the examiner that A, you know what to do, B, you've seen it before, and C, that you can do it in a safe way for your patients. And I think it's a great way of having a methodical structure to your answers, allowing you to hopefully answer all the potential questions they would give you for the approaches to any joint. But in fact, from the elbow, you realistically probably only need to know 3, but there are a lot more that you could learn if you wanted to. Thanks very much. So now I think I pass back to Adam, or straight to Andy.
Thank you very much, Matt. That's fantastic talk. I will hand straight over to Andy, who's going to talk to us about elbow trauma. Once again, just a reminder to everybody, do fire in questions on the Q&A button, and we'll do our best to answer those.
Hello, everyone. Is that everyone hearing me and seeing that okay?
Yep, that's great, Andy.
Perfect. So, hi, my name's Andy Wright. I'm going to talk to you a bit about elbow trauma for FRCS. So, what we're going to cover today. So, first of all, I'm going to look at my top tips for the FRCS trauma viva. Secondly, we'll look at the high yield elbow cases, so the things you're most likely going to get shown and have to talk about. And then finally, my way of navigating the viva. So I'm preaching to the converted a little bit here because you've all turned up for this webinar tonight, but this is the importance of the elbow in my FRCS viva. So as you can see here, both through the clinical and viva, I had elbow cases throughout, and in the viva section itself, in adult path, trauma and peds, I had an elbow case in each one. So really important you don't neglect your elbow revision. So top tips for the viva. Some of the best advice I got before the exam was about thinking of it as a tennis match. So in the first 30 seconds to a minute, the examiner's really assessing whether you're a pass-fail candidate. So it's really like knocking up in a tennis match. You're getting relatively simple questions. You should be able to bounce the answers back, and really the examiner's getting you through that pass-fail section. After that, the questions will ramp up, they'll get more complex, and that's really the chance for you to start showing your knowledge, showing all those hours you've put in, and start hitting some winners, hitting some, really giving them some really good tidbits of things that you've picked up that you can get to those top marks. And finally, it's really important to understand that they will push you as far as you know. So by the end, you'll be diving around, scrambling for answers, because they're trying to push you to the limits of what you've picked up. So don't be disheartened by the end not knowing the answer to the last few questions. That's merely them trying to find what level you're at. Secondly, really imperative you share how you're thinking. I'm sure we've all been in trauma vivas, so I've certainly been in trauma meetings where I've asked people to share their thinking. Tell me what I asked them about a fracture, and all I met with is silence. Now, I don't know if that silence is because they don't know the name of the bone they're looking at, or are they deliberating between recent publications that have come out about the management for a type of fracture. Thinking back to my FRCS viva, I was shown a complex proximal femoral fracture with a severely arthritic hip. So you need to say all that. This is a complex femoral fracture around an arthritic hip. This gives me dilemmas about treating it. If you share what you're thinking, the examiner knows you're getting into that safe and reliable colleague that Matt was just talking about then. And that echoes my final point. Remember the level. This is something Matt spoke about last week, and he's touched upon during his presentation. Really important to remember the levels as a day one consultant. They're not expecting the professor of orthopedics, they're not expecting really senior knowledge. They're expecting a safe and reliable colleague. So having a broad range of knowledge is the optimum, not having depth knowledge of 2 or 3 topics. Okay, so high yield elbow trauma. So I don't know about you, but coming through training, the elbow was always sort of a frightening area, really. There was so many different areas. Each anatomical area had a different name, and each area could be fractured independently and had its own classification system. So complexity on top of complexity. So if we're thinking about distal humerus fractures, there's the AO classification, Schatzker for olecranon fractures, Jakob for those lateral condyles in the pediatric population, E for those capitellar coronal shear type fractures, Regan-Mori for coronoid, Bedo for radial head, and Montesia for those proximal, ulnar, and radial head dislocation fractures. So, you know, where do we start? There seems to be so much complexity. So if we look at those more in a list format, well, if we leave the pediatric cases to one side, because they'll be covered at another time, and really the distal humerus and olecranon fractures, you know, my feeling for those is that the complexity that they can add in with those is really around open injuries or neurovascular injuries. And clearly you've got your Bose guidelines to rely on for those answers. Coronal shear capitellar fractures, I think that would be very unlikely for them to ask. So that really leaves those top three. So let's look at those in a little more detail. So first of all, delineating each of these injuries, we've got these classification systems, which I'm sure you know. So looking at radial head, we've got those Mason classification from 1 through to 4. Coronoid fractures, that's original Regan-Mori classification, and the Montesia fractures classified by Bedo. But I'm afraid it gets more complex again. So this paper by Van Riet from the Mayo showed that even with those type 2 radial head fractures, those relatively undisplaced, they're associated can be associated with a significant soft tissue injury, which makes you think the elbow is sublux or dislocated at the time of fracture. Those coronoid fractures, they were originally from a lateral radiograph, and obviously imaging has progressed over the years. And O'Driscoll's further classification, looking at each individual of the area that's coronoid is fractured, again adds that further level of complexity, which, you know, makes things more complex. And finally, Montesia fractures, Jupiter came along and again split down those type 2 fractures, adding a further classification. So, you know, on the face of it, this is all getting rather confusing. But the one thing that ties all these together is they're all associated fracture dislocations of the elbow. So whenever you see an elbow fracture, you've always got to be thinking, has this elbow dislocated? And I've just not seen that X-ray, thinking about the soft tissue injury as well as the fractures you see. Now here in Wrightington, we've put all those together in this Wrightington classification system that Adams pioneered. Those Montesia fractures are really come along on that right-hand side in the diaphyseal area. And the radial heads and coronoids are dealt with more in the A, B, and C that you see. Now, this may appear quite complex on first look, but let's just pull a few points out of this. The importance of the coronoid is key. So looking at the coronoid from left to right, so the antero-medial is the antero-medial coronoid. B is bifacet, or the whole of the coronoid. And C is the anterolateral coronoid that's been fractured. And again, don't forget the soft tissue injury that goes along with this dislocation, the lateral collateral ligament. So this system really gives you a way, not only a way of classifying the injury, but also most importantly, how you're going to deal with it, how you're going to treat it. So let's look at a couple of cases using that system. So first of all, this is your classic fracture dislocation. So looking at the AP and lateral, we're looking at a posterolateral dislocation. So the ulnar and radius has gone posterior and lateral. That's the majority of fracture dislocations happen this way. We can see bone fragment here sitting anteriorly to the distal humerus, and also some bone here sitting anteriorly on the lateral view. So the elbow is dislocated and there's a fracture going on. So we'll want to examine the neurovascular status of the patient. We want to reduce this elbow under conscious sedation, and clearly we want to rule out an open injury. So I want to see post-reduction X-rays to gain further information about this injury. So looking at the radial head, I can see that it's a comminuted fracture. There's bone here and bone further down on the AP, which may be from the radial head. Looking at the lateral, you get this classic fragmentation, which is often you think, I don't know if this is radial head or coronoid. Now, this is classical coronoid fragmentation. It gets pulled proximally by the anterior capsule of brachialis. So when you're seeing these fragments here, you're thinking coronoid injury. So I'm assessing these radiographs. I'm seeing a comminuted radial head fracture and a coronoid fracture. I want a CT scan to assess the coronoid in more detail. As we talk with our Wrightington classification system, we want to know which bit of coronoid is involved and how much is involved. And we want to look at the radial head to see how badly fractured that is. Clearly, with every operation for this patient, we want a radial head replacement on the side. It must be, I've also got to mention this point, the key to elbow surgery is getting early range of movement. We all know through our training that elbows get stiff, and the way to combat is to get the elbow moving early. And how we get the elbow moving early is we stabilize it, and intraoperatively we make sure it's completely stable on the operative table so we can mobilize the patient early. So the CT scan. One more thing to mention about the exam, I was quite surprised for the exam how many CT scans and MR scans I was shown that I had to interpret. So it's really commonplace that you're shown images like this. So coming around to the radial head here, we can see it's highly comminuted. This is a fracture that's maybe fixable, but highly likely we're going to need a radial head replacement. So that needs mentioning. Looking at our coronoid, in particular our antero-medial facet, that looks intact to me on there. So that's really important, thinking back to our classification system, about whether we need to deal with that coronoid intraoperatively, whether we need to talk about Matt's Hotchkiss approach he's just been through with you there. So CT scan, antero-medial facet looks intact. There is some comminution, most likely from the anterolateral facet, and a comminuted radial head. So going back to our Wrightington classification, we're looking at a comminuted radial head with an anterolateral facet, and that's coming in as our Wrightington C. So we're talking about fixing the radial head, not forgetting that soft tissue injury, dealing with lateral collateral ligament, and then on the table, I'm assessing their elbow stability to seeing whether I need to go on and deal with the medial collateral ligament. We've already said we don't think we need to fix the coronoid in this instance. So let's have a look at one more case. So again, we can see a dislocation in the elbow. It's not as clear on this whether it's gone posterolaterally, which is the most common, or just straight posteriorly. But looking on the lateral, we can see that telltale bone anterior to the distal humerus, which is most likely coronoid fragment. We're checking the neurovascular state of the limb, and under conscious sedation, we want to reduce that elbow. So clearly this has been an A&E reduction because the radial head's gone everywhere. And again, we're discussing our thought process, saying there's high comminution of that radial head. I definitely thinking about a radial head replacement is an option for this patient. That telltale bone on the anterior distal humerus looks rather larger in this case, so my concern is about the degree of coronoid injury. I'm assessing that further with a CT scan. Again, sharing my thought process. The elbow is dislocated on the CT scan. This is a highly unstable elbow. It will definitely require surgical fixation. Looking at my coronoid, there's a large chunk there which appears to extend medially. So is it bifacet or anteromedial facet involved? And again, the radial head's highly comminuted. So remembering back to our Wrightington classification system, we were looking at a comminuted radial head and a bifacet coronoid fracture. So we're not over here on the A side because of the radial head injury and the bifacet, we're looking at a B+. So how are we dealing with this? We know we need to fix the coronoid. We know we're going to have to discuss that Hotchkiss approach. We're also fixing the radial head or doing a radial head replacement. And we're not forgetting that lateral collateral ligament that needs repairing as well. So to summarize, really important you start simple, answer those first few questions, get that pass mark before you can then strive on for those higher levels. Remember the level they're looking for. That's that day one consultant, safe and reliable colleague. And when you're looking at those x-rays, recognize the coronoid fracture, the degree of involvement of that bifacet or anteromedial facet, and don't forget the soft tissue injury. Thanks very much.
Great. Thanks very much, Andy. Very nice talk. There's one question that's come in from Etif Mahmood. Any advice on fixation versus replacement for the radial head?
Yeah, so in a viva situation, you are going to say, I'm going to have the option of fixation and radial head at all times surgically. I'm going to assess it intraoperatively. And clearly there's been papers about whether there's more than 3 fragments. There's a highly likelihood that it's not going to be fixable, but it's more something that you're going to do in a viva situation. Say I've got all the options available. I'm going to assess it intraoperatively. Clearly, if I'm able to fix it, that's going to be my preference.
Do you have any rules of thumb, Andy, about the number of fragments that would help you decide whether you can fix it or not?
So if there's 3 or more fragments, I'm thinking more that I'm going to need to replace the radial head rather than fix it.
Yeah, so that's from a paper by Ring, but even Ring himself says that you shouldn't necessarily pay too much heed to that. It's more about, you know, the actual anatomy of the fracture, and in a young patient, I think you're going to try harder to fix it. In an older patient, you might accept the bone quality is poor, and you might want to replace it. Another question, Andy, about the situation, terrible triad. You've done a lateral approach. If there's a chance you might need to go medially, do you do 2 separate incisions or a single midline posterior incision?
So as Matt sort of kind of addressed when he showed those pictures of fracture dislocation, our preference is to do a 2 incision. So I'll address the lateral side, then fix the coronoid from the medial side where you get the best view. And the most common case, the most likely case you're going to see is that first one I showed, that posterolateral dislocation, where you've got radial head fracture and an anterolateral coronoid fracture, which doesn't or usually doesn't need treating operatively. So that's, you know, clearly if it's unstable after you've dealt with the lateral side, you're going to consider that, but the majority of the time that anterolateral facet does not require surgical fixation. I can see some of the questions here about isolated anterolateral facet, and that's really unusual with that. So the way the elbow is dislocated, the radial head will have to fracture in order just to have an isolated anterolateral coronoid fracture.
But also gaining access to the coronoid through a posterior approach is difficult. Gaining it through a medial approach is relatively easy, and you get a beautiful view of it, and it's easier to plate through a medial approach.
So I think it's very important with any surgical approaches. You should be using the most direct approach to the pathology that you want to treat. You don't want to be raising big flaps, because that can cause problems with the soft tissues. I think, as Matt mentioned.
So many questions. So terrible triad. So we would always...
the radial head, Andy.
Sorry,
screws or plate for the screws or plate for the radial head.
We very much prefer screws rather than a plate.
And why?
Because of the prominence of the metalwork. So there's always, they talk about this safe corridor. So, but we want to try and avoid that metal lying laterally. Clearly, with screws, you can bury those in the bone. It sort of takes away a lot of that problem for you.
So there's a really great question here, and maybe Matt as well wants to come in on this. Is there any place for conservative management of an elbow fracture dislocation in your view?
Oh, Ran wants to come in, I think.
So I think it's a very good question. I think, you know, it all depends on your patient. That's the key factor, and you have to highlight this in your examination, because you have these plans, you have these management options, all these understandings of how to fix them, but there's not always, just because you can doesn't mean you should. Particularly in this current climate, we are having discussions left, right and centre about the appropriateness of certain operations during a COVID time, and this just highlights that you really need to have an understanding of the risk profile associated with the operation, patient comorbidities, but also the risk to the patient of the surgery. And so I think there's always a place for conservative management in a large proportion of fractures. If the patient factors are, have lots of comorbidities, there's a very old age, poor function, poor mental status, then yes, there is always a place for conservative. However, There's also a very good place for early fixation and early mobilization, and having a stable elbow leaving the table, which is ideally what we want from a surgical point of view.
So our default position is you need to stabilize the elbow and get it moving early. So what I think that's what's trying to highlight is there is clearly an exception to every rule, not least COVID in the current times. But our default position is we want to stabilize the elbow to get it moving as soon as possible.
And I'd absolutely agree with my two colleagues on that. There are situations that you will encounter where you might have, for example, a terrible triad, where on the CT scan the elbow is perfectly congruently reduced, and the bone fragments, the coronoid and the radial head fragments, are almost undisplaced. And it's quite possible in that situation that at the time of the injury, there wasn't a significant subluxation, and therefore the soft tissues are intact. And it is reasonable in that situation, which is pretty rare, to try non-operative treatment, but it's not neglect. It's cat-like observation. So you bring that patient back every week and you re-examine and you re-x-ray them and make sure they're not drifting off. But exactly as my colleagues say, you've got to make sure that they are stable, because if you leave these, salvaging them can be extremely challenging. Sheriff, we're not going to answer the question about which system is biomechanically superior. I'm happy to take that offline. And in the case of terrible triad, Andy, what's the sequence of fixation?
So we'd start laterally, so addressing the radial head, addressing the lateral collateral ligament, and then assessing stability. As I said, terrible triads most commonly fit into that type C category. It's the most common you see. And so the lateral side is usually sufficient to get the elbow fully stable. And just picking up Alexander Curran's question at the bottom, that usually we're assessing the elbow intraoperatively, and we want the elbow to be fully stable so we can start post-operative mobilization immediately. If it's not fully stable, that's when we're considering what else do we need to do. Do we need to go immediately? Do we need to repair the MCL or address that side?
From a positioning and approaches point of view, you're supine arm board, so you're doing your lateral approach, your modified cockers, and then all you need to do is close up, and then you externally rotate, and you can go on and do your medial approach. So there's no repositioning, you know, redraping. You can do it all through, which is lovely. And
just thinking about the FRCS exam, you really want to have your own way you're going to address these questions. So we've already told you our thoughts. So you're seeing a fracture or dislocation in the elbow. So you start saying, this is an unstable injury, and my intention is to manage this operatively so I can stabilize the elbow and get it moving early. Now, clearly there are exceptions to that rule, but you want to be displaying your thought process. That's how you're going to score the marks and get a really high score in the exam.
Great. I'll maybe come back and pick up some of these questions again at the end, but for the sake of time just now, we will move on. Sounds like we need to do another session as well on elbow trauma. It's something that causes clearly a lot of people have a lot of questions about, and one area we haven't of course covered tonight is distal humerus fractures, so there'll be plenty more options for discussing elbow trauma in the future. We're going to just take a slight change of tack now and talk now about elbow arthritis and the management of that. I'm hoping you can see my screen. So I'm going to talk about elbow arthritis. I've put in brackets in the young patient. I suppose things become a little bit more nuanced, and the decision making is more difficult in the younger patients. We're going to talk about the problem, the causes of the problem, how we evaluate it, and then the treatment options that we have available to us. So elbow arthritis is pretty common, and actually in many people goes largely unnoticed. Maybe a little bit of loss of range of movement, but not a lot of pain. But for some, pain and stiffness can be issues. And never forget that instability can be both the cause of arthritis and a result of arthritis, especially in inflammatory conditions such as rheumatoid arthritis, where you get loss of soft tissue stability and loss of osseous stability. So instability can be both causative and a result of the pathology. You don't, you know, it's a long time since I did the exam, and I'm not an examiner at this point in time, but you certainly don't want to be launching straight into offering your patients an elbow arthroplasty. As we'll talk about later on in the talk, there are plenty of issues with elbow arthroplasty that will temper our enthusiasm. And there are things that you should know about elbow arthroplasty and the factors that affect survival. So diagnosis is an important thing. So patients with post-trauma sequelae and arthritis tend to have a worse, osteoarthritis tend to have a worse outcome than a patient with rheumatoid arthritis. Male patients tend to have a worse outcome, and young patients tend to have a worse outcome from elbow arthroplasty. And those who perform high activity levels. Now, actually, you could probably argue that age, gender, and diagnosis are really just surrogates for the last point, because it tends to follow that the younger the patient, the more high demand they are in terms of activity through their elbow. We do tend to give our patients guidance on what they can do with their elbow after a joint replacement. And we typically say no more than 10 pounds on a regular basis and no more than 2 to 3 pounds. Sorry, that 10 pounds should be a one-off and 2 to 3 pounds on a regular basis. And we often say no limits after hemiarthroplasty. These are pretty arbitrary, and actually there's no evidence base for any of these figures, but it's pretty well accepted worldwide that these are the sort of figures that you quote. But a really nice study from the Mayo Clinic showed that actually, despite 64% of patients saying that they accurately remember the instructions they were given and were trying to be compliant, 94% of people perform moderate demand activities. So it doesn't really matter what we tell our patients, they will go off and they will do exactly what they want to do with their elbow. 40% will perform high demand activities. And that includes shoveling, putting luggage overhead. I noticed sexual intercourse comes under moderate demand activities. They're obviously not doing it right, but the demands are there. The other important thing is that those with fractures and non-unions are twice as likely to participate in high demand activities than those patients with rheumatoid arthritis. And that again comes back to that earlier data that I presented to you. But it is worth remembering that the implant survival rates that we report, both from clinical studies and from registries such as the National Joint Registry, are based on what patients do, not what we tell the patients to do. So it's important to bear that in mind. So if we're not going to reach straight for our joint replacement for every case of arthritis, we need to have a better understanding of what is going on. And just as my colleagues have said in the earlier talks, you need to have a structure and an approach to answering any question. There are various causes, potential causes for arthritis, and each of these can present at different times in life and with different causes. So idiopathic arthritis tends to present from the 6th decade in life, and there is an association with heavy manual work. Inflammatory arthropathy can present at any time really, but often from the 3rd decade, and often there'll be a family history associated with that. People with developmental problems and secondary arthritis to those things, such as congenital radial head dislocations or developmental radial head dislocations or developmental elbow subluxations, will typically start to present in the second decade of life, and often there'll be syndromes associated with those things. Then you've got post-traumatic causes, which is a common issue, and infection, which of course has to be in your differential diagnosis for cause of really any condition, should always be on your sieve. So let's just consider a little while inflammatory arthropathy. So you should be aware of the Larsen scoring system. I know that that there has been a move away from grading systems, but there are some that are actually useful, and the Larsen is one that's worth just remembering, which goes from 0 with an intact bony outlines and normal joint space through to 5, where you have mutilating change. And our management will be largely guided by this. So when somebody with significant destruction of the joint, you're really looking at arthroplasty rather than a lesser option such as synovectomy or radial head excision. But these options are available to us. So if medical management has failed, and synovitis is often very well managed by the physicians, either with oral medication or with intra-articular injections, then occasionally we will be asked to look at surgical approaches, and this can be performed either as an open or as an arthroscopic procedure. Radial head excision in the young inflammatory arthritic patient is a good temporizing option. Very often their pain will be arising from the radiocapitellar joint in the first instance, and while we are very reluctant to remove the radial head in all patients, in rheumatoid patients there may be a role for a radial head excision to provide pain relief, to temporize their elbow, and try and avoid the need for an elbow arthroplasty for as long as possible. It does have long-term sequelae in rheumatoid patients, just as in osteoarthritic patients, in that if you remove that lateral stabilizing structure, then your elbow starts to wear the anterolateral facet. You get overload of the anterolateral facet. And particularly in rheumatoid patients, where their soft tissues may become attenuated because of synovitis, their medial ligament will start to stretch out, and they'll drift into this valgus pattern. So it's important that you're aware of that when counseling the patient. But is synovectomy and radial head excision a reasonable option? How does it compare to total elbow replacement? So one study looked at this and looked at age-matched elbows, and what they found was that you have ongoing or recurrent pain more commonly after synovectomy and radial head excision, but the complication rate is higher after total elbow replacement. So you pay your money, you take your choice, but those are the options. I think the important thing to know is obviously that the survival for a total elbow replacement, we normally quote a rate of about 85% at 10 years, is better than the alternative of synovectomy and radial head excision. But that may be because there is always another option after that of a total elbow replacement. What about this sort of situation? So here you can appreciate that there's loss of joint space of the ulnar-humeral joint as well as the radiocapitellar joint, and in that situation probably a radial head arthroplasty if they have pain which is keeping them awake at night and severely affecting their quality of life would be a reasonable option. So using the Larsen scoring for those 1 to 4, we take a tailored approach based on those factors that I've outlined there, but we try and avoid arthroplasty. But when they reach stage 5, then they're probably better off with a total elbow replacement to give them a longer lasting outcome. So moving on to osteoarthritis. So osteoarthritis, as we talked about earlier, can be idiopathic, it can be post-traumatic, and can be caused by developmental problems with the elbow, and it can be caused by infection. Your textbooks won't tell you, but I can tell you that you will see different radiographic appearances. So some will be hypertrophic, some will be erosive, and some will have a combination of the two, and I'll show you some illustrations of those things. And then you can consider which articulations are involved. So if you're faced with an X-ray is placed in front of you, it's a slam dunk of osteoarthritis, but if you want to start scoring more points, start saying, well, this is a hypertrophic form of osteoarthritis involving the ulnar-humeral joint or panarticular. You'll be scoring more points. And that's what we're seeing here, a hypertrophic picture, where you've actually got a relatively well-preserved joint space, where you've got osteophytes, which have been formed around the margins of the joint, which will limit the range of movement and will often cause pain, impingement pain at the limits of movement. This more erosive picture, in this case, it's affecting the radiocapitellar joint, will give pain often through an arc of movement and often made worse by loading. And these are the features that you can start to draw out from your patient. Not too many osteophytes in this case. And then the combined cases where you have significant marginal osteophytes and loss of joint space, which gives you that sort of picture. In the history and the examination, the things that you will want to tease out around pain, they may have none, but if they have none, it's unlikely that they will find their way to you. Although some patients will come just reporting loss of range of movement in the elbow. They can have pain at the end range, and that's often with osteophytes and impingement pain. Through range is when it tends to occur when they're losing the joint space. And then patients with night pain would start to raise the indication for an arthroplasty, but also you'd want to consider other diagnoses such as infection. When you're assessing stiffness, you want to know whether that stiffness is intermittent. Does it come and go? If it does, and it's a symmetrical loss of range of movement, that would be consistent with an effusion in the elbow. Or is it consistent? And if it's consistent, is it progressive? So are they losing range of movement over time? Obviously, you'd ask about a history of trauma or heavy manual work, and I specifically ask the patients about mechanical symptoms and any neurological symptoms. And if they have mechanical symptoms, it may be because of loose bodies in the joint, and that's a relatively straightforward thing to address. You can often see them on X-rays. If you can't see them on X-ray, then CT or MR arthrography can be helpful in making the diagnosis. Impingement symptoms, as we've talked about, you can appreciate on this CT scan how those osteophytes sitting in the olecranon fossa and the coronoid fossa will limit the range of movement and will cause pain at the extremes of movement, but no pain through the arc of movement. And we talk in the elbow that millimeters make inches, so you don't need a very big osteophyte to lose quite a lot of range of movement, which can affect function. And in that situation, we can use arthroscopic arthrolysis to remove those osteophytes, to improve range of movement and pretty reliably relieve pain. There are situations where an open arthrolysis may be preferable. And that's where you have very significant marginal osteophytes, or where you have metalwork in the joint. And it's really just a matter of time. It would take so long to remove these osteophytes, and clearly you're not going to be able to remove all of this metalwork arthroscopically. So an open procedure is more likely to be successful. And very often in this sort of situation, we're removing metalwork and taking biopsies with the view that if we need to do an elbow replacement in the future, we're at least dealing with a better situation than we started with. But you'd be amazed how often you take out the metalwork and the patients will say, actually, I can live with the elbow now. Lateral elbow pain on loading. We've talked about how this picture represents radiocapitellar osteoarthritis, and they'll present with lateral elbow pain. It should be in your differential diagnosis alongside tennis elbow, but not all lateral elbow pain is tennis elbow. So you should need to consider this as an alternative diagnosis. It's not always symptomatic, so it can be an incidental finding. And it can be a sequelae of trauma or osteochondritis dissecans. So very often they'll say, I had problems with my elbow as a teenager. Often they were told they had tennis elbow as a teenager, which is an incorrect diagnosis. But there may be a history of heavy manual work or sporting activities. And a really useful test is the grip and grind test, where you get them to grip your fist and then rotate the forearm. And if that reproduces their pain, then that suggests a radiocapitellar arthropathy. Can we just take out the radial head? Well, just as in the rheumatoid population, we don't want to do that. It will lead to valgus collapse of the elbow and progressive arthritis of the anterolateral facet. And it can cause problems with proximal stump impingement and forearm pain. So radial head excision in these patients is a bad thing. What we need to do in the case of radiocapitellar arthritis is to determine what are the causes of pain. And there are lots of things. So it's damage to the articular cartilage, periarticular synovitis, impingement, loose bodies, a plica radiocapitellar plica, and instability. And all of these can be causes of pain in radiocapitellar arthropathy. And if you address each of those in a logical sequence, then in most cases you don't need to remove the radial head, and that's been shown in one series reporting good pain-free elbows with improved range of movement, even with preserving the radial head. So don't jump in and take the radial head out. What about the situation where you have through range pain and pan-articular arthritis? Physiotherapy, no evidence of benefit of that, but our aims are meant to maintain muscle quality, proprioception for protection and avoid extremes of load. Splinting and strapping can be helpful. And there is a role for intra-articular corticosteroid injections. Obviously, we have concerns at the moment because of COVID, but in normal times, that would be a reasonable temporizing measure. Hyaluronic acid has been shown to be of no greater benefit than steroids in the post-traumatic arthritis group, but we don't know about the idiopathic arthropathy group because that study hasn't been done. And then the last resort, well, if you've exhausted all other options, then total elbow arthroplasty is a reasonable option. But if you're going to start talking about total elbow arthroplasty, then you need to know a few things about it. John Stanley, who founded the Wrightington Upper Limb Unit along with Ian Trail, talked about this algorithm for deciding in the young patients whether they need a total elbow arthroplasty. You'll need to access that on YouTube. I'm not going to go through it in detail, but it gives us a useful scoring system to decide when a patient needs an elbow replacement. But obviously, it's a patient-by-patient decision. You need to know for the exam about the complications of elbow arthroplasty. Nobody's going to ask you great detail about how to do an elbow arthroplasty, but you must know the complications. So infection is more common than in many other types of arthroplasty, between 3 and 5%. Ulnar neuritis can affect about 10% of patients after elbow arthroplasty. Fractures, either intraoperatively or postoperatively, are probably more common than are reported in the literature. And heterotopic ossification is a common problem, but doesn't normally restrict movement. And then there are implant problems. So aseptic loosening is the most common cause of failure. Dislocation, if you do an unlinked arthroplasty, polyethylene wear, and implant failure. And again, that really depends on the type of implant that you use. And that's on top of all the usual complications associated with surgery, which you should, I'm sure, all be aware of. You should probably, for the exam, have an idea of options of surgical approach, and even better if you have your preferred surgical approach. But again, probably for the exam, you wouldn't be expected to go into too much detail. There are lots of approaches that can be used. Our preference is to use a triceps sparing lateral paraolecranon approach, which I'll just very briefly show you in a video here. So we make an approach on the medial border of triceps, leave the ulnar nerve in its bed, but do an in situ decompression, and then elevate underneath the ulnar nerve all the soft tissues off the medial epicondyle, and then do an extended Boyd approach on the lateral border of the ulna, and split the triceps so we leave the bulk of the triceps tendon attached to the olecranon, remove the fat pad, and then dislocate the elbow through the lateral window. And the benefit of that is that it enables us to do better soft tissue balancing. I think really importantly for the exam, you must be aware of the data from the National Joint Registry, not in great detail, but at least the headline details from it. The elbows have been recorded in the NJR since 2012. The new report for this year will be coming out shortly, but this is last year's data. And there are a total of 2,640 total elbow replacements recorded, the biggest series in the world, although the numbers are still very small. Only 400 elbow replacements are done a year in England and Wales annually. The most common indication in the UK is inflammatory arthropathy, 50% of cases, and osteoarthritis, a third of cases, and trauma sequelae, you can see there, 15%. It's interesting just to be aware that the number of elbow replacements done for trauma is on the increase, and this is partly because of an aging population and more smashed distal humeruses requiring arthroplasty, but possibly also change in surgical trends. And you don't need to know huge detail about different types of implant, but in the off chance that somebody hands you an elbow replacement and asks you to talk about its features, you should be able to at least talk about the fact that this is a linked elbow replacement on your left-hand side and the unlinked on the right-hand side. You should be able to talk about the sintering on the stem, which might seem a little bit illogical given that these are cemented implants, but it's because of concerns about pull-out of elbow prostheses and aseptic loosening. And talk a little bit about the articular bearings being polyethylene on metal in really every example. And that you should be aware that there are unlinked, linked, and linkable devices, so that can go in either as an unlinked option or here with a cap as a linked option. One really important thing, and one of my big bugbears, is that people often use the word linked to mean constrained, but linkage and constraint are two independent variables. So this is a chain, this is a linked device, but it is unconstrained. So I can make any shape with that link that I like because it's unconstrained. These two cups are unlinked, but if I put them together, they are highly constrained, and you will have one-to-one movement between the top cup and the bottom cup. They remain unlinked, but they are highly constrained. So constraint and linkage are independent variables, and that's really important to understand. If you look at all these types of arthroplasties, they will all fail in different ways. So these are all unlinked arthroplasties. This Suter Strathclyde, very constrained, tended to fail with polyethylene wear or loosening. This capitellar condylar, unconstrained, would fail by dislocation. And the same is true with linked implants. So you can change the anatomy of the linkage to change the constraint. what most implants are aiming for when they're linked is that you have 3.5 degrees of varus valgus play around neutral, but it does mean that your forces increase dramatically. What you ideally don't want is this sort of picture, which is a linear increase in force with angular displacement, because that will lead to early loosening. And the geometry of the articular surfaces also affects the wear, and that can then lead to earlier failure. So it's important to know about those things. You'll probably be aware that nowhere else in the body do we do linked arthroplasty. And why is it that we do it in the elbow? It's because we have problems with instability with unlinked arthroplasty. But there are certain advantages, and maybe if you're going for the gold prize, you'd want to talk about the advantages of unlinked versus linked arthroplasty. And that is that the forces can be absorbed by the soft tissues. And there's good evidence for that, but unfortunately it's not borne out by the survival of the implants. So here the blue line is the survival of the unlinked implants, and the red line is the survival of the linked implants. But delve deeper and you can see that that's just due to historical unlinked implants. So at the moment we don't actually know whether unlinking an implant is a good idea or a bad idea, but in principle it's meant to be a good idea. You should be aware of the survival rates reported from the NJR, which don't quite reflect the survival rates published from case series in the literature. And we only have data up to 3 years. We only have data up to 3 years. Reliable data up to 3 years, I should say, and there's no significant difference between trauma and elective elbow arthroplasty survival, which is approaching 5% at 3 years. And really importantly, I think as well, you should be aware of the Getting It Right First Time project, which was pioneered in orthopedics, and elbow arthroplasty is going to be one of the spearheads of that project, trying to reduce the number of centres performing elbow replacement to try and improve survival and outcomes for patients. And you should probably also be aware that BESS has produced surgical procedure guidelines for elbow arthroplasty. Just finally, just to wrap up, neurectomy is an option, but nobody does it. Interposition arthroplasty is an option, but the survival or the success is pretty hit and miss. About a third do well, a third do badly, and a third are about the same as when you started. Allograft arthroplasty is a disaster. It just fails because it's not innovated, and fusion is the ultimate salvage option. But in my 11-year career, I've done 2 fusions, so it's a pretty rare thing to have to do. There's no good position to fuse an elbow, and so if in the exam you find yourself saying fusion for the elbow as an answer to any question, just think twice as to whether that's the right answer. And just be aware that sometimes there are situations where we have no good solution. So this is a patient with post-polio syndrome who uses their elbows as legs or as knees, and they have an unstable osteoarthritis, but you wouldn't want to do an elbow replacement for that because they're going to fail pretty quickly. So just lastly, these are my algorithms. So if it's stiffness that we're treating, then I'll do an arthrolysis, mainly arthroscopic. If it's post-trauma and they've got metalwork in, then certainly open. If they've got pain, ask yourself, is it impingement pain? If it is, then an arthrolysis, normally arthroscopic. If it's through range pain, if it's purely radiocapitellar, then an arthroscopic arthrolysis will normally do it. If it's only humeral, then you can try injections, analgesia, but if that doesn't work, then arthroplasty is a reasonable option. And if they have rest pain, just ask yourself, is there any concern about infection or tumor? And if you've ruled those out, then go down the same route as the ulnar-humeral arthritis. Thank you very much indeed. So, any questions from that? So why is there a higher infection rate and neuritis compared to other arthroplasties? We don't really know. It may be partly because of the population that we're treating, who tend high volumes of rheumatoid patients who are obviously immunosuppressed. But nobody really knows the answer to that. People have said it's because the elbow is closer to the skin, but I don't believe that. It may be because each of us does fewer elbow replacements, and maybe we're just not as good at it as we are as knee and hip replacements. But the honest answer is we don't know. Is there a problem with repeated injections? Well, we certainly don't encourage repeated injections. How many is the maximum? Well, normally most people would say 3, but that's pretty arbitrary. Is there a role for the OK procedure? So the OK procedure is just a technique. It's a way of removing osteophytes. I personally do, if I'm doing an open arthrolysis, I use a column approach rather than OK approach. And actually, I tend to use the arthroscopic technique more frequently. But an OK, if that's what you're used to doing, is a very reasonable answer to any question. Can you do total elbow for patients with previous synovectomy and radial head excision? Absolutely, you can. There is no evidence that the outcomes are worse. So that is a reasonable approach to take. Amit Bidwai is asking about neurectomy. Essentially, with a neurectomy, there's a 3-incision approach that's described, and you basically come around all of the major nerves and try and take any of their branches that are supplying the joint. You could probably imagine that this is quite a significant dissection, and the morbidity associated with that is pretty huge. There's one case series reporting really fantastic results for neurectomy, but it certainly hasn't caught on and is not in common use currently. So again, for the exam, I maybe would mention that neurectomy has been explored but is not currently practiced. Any other?
One moment.
Great. So, are there any questions for any of our speakers? No. Are there any coming through? What are the indications for radial head replacement with total elbow arthroplasty? So it depends on the implant that you use. Obviously, the right medical latitude implant has a radial head replacement component with it. You don't have to use the radial head component, and we tend not to unless that we absolutely need to. We tend to leave in the native radial head where possible, which there is some value in having a radial head because it is load sharing, and there is evidence even with arthroplasty that if you can maintain the radial head, it will prevent valgus collapse of the joint. So it is useful to have it there.
There was 2 previous questions, I think, about MRI scans for terrible triad fractures.
You want to tackle those, Andy?
Yeah, I think as we tried, or hopefully tried to stress, is that our default is to treat most fractures surgically so we can have an early full range of movement. And I think if you're, I know Adam mentioned a case with a very much undisplaced fracture pattern, but clearly there is a soft tissue element there with that. And I'm not sure an MR scan, it'll just show the soft tissue injury that you already know is present. I'm not sure it'll necessarily change your management plan, because the most likely reason you're treating it conservatively is because of other patient factors, and an MR scan is not going to change those, i.e. comorbidities or COVID.
The only exception I would say to that may be the Wrightington C's. I don't know what the Wrightington A's rather. I don't know what your thoughts are, Andy. So with the Wrightington A's, where you've got the antero-medial facet fracture, some of them can sort of seem to get away with without surgical intervention. They often can come to us a bit later, and some of them are moving pretty well. And if you do an MRI scan, you can find their ligaments are intact. But again, just as Andy, you said earlier, I think you've got to have a very low threshold for intervening, because if you get it wrong, they'll get arthritis within a year, which is pretty devastating. I don't know if you have anything to add to that, Andy.
Yeah, I think it was about terrible triads with that question, but obviously if the Wrightington A is not a terrible triad because the radial head is not involved.
No, that's right.
There was also a question about our role of hemiarthroplasty. So I think, speaking from the unit's behalf, is we use hemiarthroplasty particularly with distal humerus fractures. So in some of our cases, if it's unreconstructable, if you find that you're a high chance of your fixation failing and you have distal shells or fragments, then yes, we do use hemiarthroplasty, particularly with distal humerus fractures.
Great.
The last one's about coronoid fixation.
Coronoid, yeah. Do you want to answer that, Andy?
I was just throwing it to you.
Oh, is it to me? Thanks. So for fixing small coronoid avulsions, the first thing to say is they're not avulsions, okay? Because if you think about the anatomy of the elbow joint, the capsule actually inserts distal to the apex of the coronoid. And these are drive-throughs. As the forearm is subluxated dorsally, the coronoid has been pushed off. And that's really important. I know it sounds like I'm being picky, but it's important to understand that when assessing the injury, because you need to think, where has the elbow been to result in this? In most cases, as Andy says, if it's a small coronoid piece and it's part of a terrible triad, you can just ignore it. If it's an isolated coronoid, then it's almost certainly an antero-medial facet fracture, and that you need to take more seriously. And if it's small, I would fix it arthroscopically, but otherwise, because it's actually easier, but otherwise an open approach, as Matt has described, a medial Hotchkiss approach would be the way to go. So I've got some questions for you guys. Hopefully this is going to work. So can you see that poll? So which of these approaches do you use a true internervous plane? So you can choose as many as you like. Kaplan, Cocker, Henry, Alonso Lammers, Hotchkiss, and triceps split. And Matt, maybe you want to talk to the responses when I stick them up in a moment. Just giving people a chance to respond. Okay. So there, can you see the results there? Can you see that, Matt?
Yeah, we can see those.
Yes, I can. Yes, we can. Thank you.
Do you want to just talk through that?
When it comes to the internervous plane, it's key that the leading question after is going to be the nervous innervation of it, and that you know the roots of the nerves. So when it comes to, you've highlighted Cocker approach, we've gone through the Cocker approach, you're absolutely right. There's nervous innervation of both of those, which are different, as therefore it's an internervous plane. And then obviously we'll lead on from that is the course of the nerve, the nervous intervention as well. Yeah, 88% are correct.
Yeah, it looks very good. So, the capillin is not an intimate nervous plane. Cocker is, Henry is, Alonso Lammers is not, Hotchkiss is. And triceps split, of course, not. So it looks good. Okay, next question. So the radial nerve can be found between the two heads of supinator, between brachioradialis and biceps, 2 centimeters proximal to the apex of the triceps aponeurosis, and 4 centimeters distal to the radiocapitellar joint line in the mid-lateral radius. And I'll just, as a clue, tell you there's a catch in this question. That's partly for Matt when he has to answer. So I'm not setting any bear traps.
This one's all yours, Adams.
Thanks very much. Okay, so between the two heads of supinator is the posterior interosseous nerve, a branch of the radial nerve, but not the radial nerve. Yes, you can find the radial nerve between brachioradialis and biceps, and you can find it 2 centimeters proximal to the apex of the triceps aponeurosis. Actually, a really useful landmark if you're plating the humerus. And 4 centimeters distal to the radiocapitellar joint line in the mid-lateral radius is where you will find the posterior interosseous nerve, not the radial nerve. But actually that's not a very good way to find it, because by the time you've hacked through all the muscles to get to that. But it is, if you are plating the radius, you should know that with the forearm fully pronated, the nerve will be about 4 centimeters from the radiocapitellar joint line when you're doing those lateral approaches. Oh, sorry, I didn't share the results. There's the results. All right. Okay, next question. So in a terrible triad, elbow fracture dislocation, if it looks to be in a good position in a POP after reduction, do you apply a hinged brace for 6 weeks, keep in POP for 3 weeks, then a hinge brace for 3 weeks, keep in POP for 6 weeks, then mobilize, assess further with the CT, but counsel the patient that it is likely that surgery is not needed. Apologies for the misspelling of counsel. And assess further with CT to plan operative strategy for coronoid and radial head. And again, Andy, if you don't mind, I'm going to open this one to you when I've ended the poll. So there's the results, Andy.
So hopefully that reflects the sort of conversations we've had tonight, sort of stressing
the quality of the teaching, Andy.
As we've been trying to sort of stress, is really important. Well, obviously in managing these fractures, but also entering the exam, you have a really clear strategy for managing these, and hopefully we've emphasised that. I don't think there's anything more to say.
Also about the use of plaster of Paris is probably something to raise up as well, Adam.
Expand, Matt.
Because you've got 3 of your options there have plaster of Paris application as well. And the concern of the way I've seen people apply plaster of Paris to elbow dislocations is it's actually applying a force that will actually encourage the elbow to dislocate out rather than actually protect it. And so when we do our operating on our elbows, we don't tend to do plaster of Paris. We tend to have a stable elbow, hopefully, when they leave the table and they're placed into a sling. But that's just a factor to be aware of, because some examiners may not like the use of plaster of Paris in elbow dislocations.
Absolutely. So if you think that they're not quite stable, so I'll just wrap them up in a cast and that'll make them stable, you'll be very disappointed when you see them back in a week or 10 days, because they'll be dislocated. So they've got to be stable before they leave the operating table. The most common structure to address in an elbow dislocation or fracture dislocation is the MCL, the coronoid, radial head, lateral ligament complex, or no structure. Most need a POP only. Okay, I'm going to end it there. We're all pretty much on target. Andy?
Yeah, so I obviously with time restraints, we didn't cover everything. So we didn't cover simple elbow dislocation. So that's an elbow dislocation without a fracture. But if you remember my red hoops skimming across the screen, they all circled the lateral ligament complex. So it's the most common thing you need to address.
And what you find with your approach is you come through ECU and Caneus, and then you find there's literally just bare bone underneath it as the ligament complex has been pulled off.
So in elbow arthritis, which of the following is true? Arthroplasty is the first line treatment for arthritis in the young patient. Interposition arthroplasty is a good option for the unstable elbow. Arthroscopic debridement can provide adequate pain relief in patients with the radiocapitellar OA, and synovectomy and radial head excision is as durable as total elbow arthroplasty in the treatment of the young RA patient. So I'm going to end it there. All look pretty confident that it's arthroscopic debridement is the right answer there for radiocapitellar OA. And then the last question for this evening. The following is true of elbow arthroplasty. Unlinked arthroplasty has been shown to improve implant survival. Infection is the most common reason for revision. Patients can carry unlimited load after elbow arthroplasty, and revision rate at 3 years is approximately 5%. Okay, I think most people have answered. The correct answer is revision rate at 3 years, approximately 5% from the NJR. Infection is not the most common reason for revision. It's a very important reason, but aseptic loosening is actually the most common reason for revision from the NJR data. Unlinked arthroplasty has not been shown to improve implant survival, but it's a nice theory. And we do tend to recommend restricting load. So I'm just going to stick up the last poll, which is the feedback poll. But while you're answering that, I really want to thank you all for giving up your Sunday evenings to listen to us. I want to thank all of the speakers, Andy and Matt. Thank you very much. And many thanks to Ran and to Tricia from BOTA the best president and vice president for hosting Wrightington with this series. Next weekend we have shoulders, and the weekend after that will be tumours. So we hope that you'll join us then and enjoy the rest of your weekend, what's left of it. Thank you all very much indeed. Excellent, guys.
That was really good. Thank you.
Okay, it's a pleasure.
Right. See you next week.
Andy and Matt, very much indeed.
Yeah, well done, guys. That was a really, really great, great session. All the participants are now leaving. It's still recording on YouTube, but I thought that was really, you know, it was great. We're obviously learning as we go along. So well done, everyone, and we'll catch up during the week.
Thanks.
Bye from me.